دكتورة مي وحيد. اتفضلي دكتورة.
Good afternoon, everyone. I am Mai Wahid, Assistant Lecturer of Radio Diagnosis at Ain Shams University. We are going to explore key insights into rectal cancer imaging, practical points, and emerging trends. So as a start, what is the best modality of choice for rectal cancer and other imaging choices we have? The gold standard for local staging of rectal cancer is high-resolution MRI. We also have CT for distant METs or nodal evaluation. We have EOS, endoscopic ultrasound for early tumors. We're going to talk about that later. We have PET-CT for the occult METs, and PET-MRI hybrid. We're also going to talk about that later. So, as we said, the gold standard is MRI rectal protocol. So when and how we do it. As for when, we have two case scenarios in which we do the MRI rectal protocol. First case scenario is a newly diagnosed rectal cancer case for baseline imaging or local staging, the TNM staging. Second case scenario, we have post-neoadjuvant therapy case in which we should do restaging or reassessing or reevaluating of the rectal cancer as for preoperative assessment for the surgical decision. So the technique of the MRI rectal protocol, we have three planes. The first important plane is the sagittal plane because it will localize the tumor and it will plan the axial and coronal views. The field of view, we take it from the sacral promontory, which marks the sigmoid takeoff, above which we have the sigmoid colon and below which we have the rectum itself, down to the anal canal. And the coronal view angled parallel to the tumor axis and the axial view angled perpendicular to the tumor axis, to allow the proper assessment of the tumor beyond the rectal wall and its distance between the tumor and the mesorectal fascia. What are the essential sequences? We have the T2 axial for the radial assessment of the tumor. We're going to see that later. The T2 sagittal and T2 coronal sequences for the longitudinal assessment and the levator in eye muscle affection. We have the spare fat-SAT sequence for the component of the tumor and also for extramural vascular invasion. And the diffusion ADC sequences, which is very, very important in the restaging case scenario. We'll talk also about that later. And for the lymph nodes, and the contrast-enhanced T1 weighted imaging for the extramural vascular invasion. And lastly, we have the diffusion ADC abdominal sequence for the liver deposits and peritoneal deposits. So, the first case scenario, we have assessment in baseline imaging, a newly diagnosed rectal cancer case. We are going to do the TNM staging of the case. The T stage done by the longitudinal assessment and the radial assessment, the T stage. The longitudinal assessment, as we can see here, helped by the T2 sagittal view, we can see the morphology of the tumor, polypoidal or mass. We can see the length, the upper limit, and the lower border, its distance from the anal verge and the sphincter invasion. All will help the surgeon to choose the operation, whether abdominoperineal resection or anterior resection, based on these points. And then we have the radial assessment by the T2 axial sequence. We can see the thickness of the tumor, its extension beyond the wall into the mesorectal fat, shown here by the yellow star, and then involvement of the peritoneum in the upper rectal tumors or the mesorectal fascia, shown here by the red arrow, and then the lateral invasion into the pelvic wall and the nearby organs, all in the T2 axial view. Then we have the nodal assessment, the end stage, whether locoregional or distant lymph nodes. We'll talk about that in the next slide. And the end stage, the metastasis, whether peritoneal or liver mets by the diffusion ADC abdominal sequence. The nodal assessment, we have distant or locoregional lymph nodes. The distant lymph nodes are shown here by the red color. They are considered pathological based only in size, regardless the morphology. So they are pathological if it's more than or equal 7 millimeter. While the locoregional lymph nodes, shown here by the yellow area, they are considered pathological based on size and morphology. So if it's more than 9 millimeter in short axis, or 5 to 9 plus 2 malignant features, or less than 5 millimeter plus 3 malignant features, all are considered pathological in this way. The malignant features, either indistinct border heterogeneous or round shape. On a side note, we talked about the extramural vascular invasion, which is better identified in the contrast-enhanced imaging or the SPARE sequence, which is, by the way, the prognostic feature. Its positivity gives a hint that the patient is more prone to recurrence and blood mets. And the circumferential resection margin, which is important for surgical decision, important for the surgeon, it's better identified in the T2 axial coronal sequence. Now for the second case scenario, we have post-neoadjuvant therapy case after taking chemo and radiotherapy. So this patient, we should reassess and reevaluate the tumor for surgical decision, preoperative assessment. We are going to reassess the disease extent, reassess the length, the thickness, and the mural signal, which is helped by the diffusion ADC sequence. As I said, the diffusion ADC sequence is the most important sequence in the restaging case, and the MRF assessment. And we are going to reassess the nodal response to the CRT, chemoradiotherapy, reassess the size and number, also in the diffusion sequence. And the peritoneal liver deposits and other mets. Here we can use also the PET-CT or the PAN-CT. And lastly, we are going to calculate the RECIST, which is the response evaluation criteria in solid tumors that will categorize the tumor response to the chemoradiotherapy as either complete response, partial response, stable disease, or progressive disease, based on size and disappearance of the on-target lesions, not given into account the metabolic activity or the blood flow of the tumor in response to the chemoradiotherapy, by the way. So here we can see the response assessment after neoadjuvant treatment, either complete or near complete, good or poor response, based on the diffusion findings. So it's a very important sequence. We can see here an image in the pre-chemo and the post-chemo radiotherapy. At the post-chemo radiotherapy, we have high signal in the diffusion sequence in the inner aspect of the rectal tumor, as we can see here, corresponding to a low signal at the ADC sequence. So here there is still remnant of the tumor post-chemo radiotherapy. The problem with diffusion is that it has or causes a lot of pitfalls, like shine through, dark through, susceptibility artifacts. Shine through may occur in case of small amounts of fluid in the rectal lumen, which may mimic tumor. And the susceptibility effects mainly occur at the interface between the soft tissue in the rectal wall or tumor and gas in the lumen. While the large artifacts will be easily dismissed, the subtle ones projecting over the rectal wall may be mistakenly interpreted as tumor signal. So from here, we can talk about the pitfalls encountered in MR rectal imaging, which is considered the gold standard imaging, and the trends starting to emerge to overcome the current limitations or pitfalls. For example, we can have improper field acquisition, conventionally high matrix size with thin slice thickness, small FOV to achieve high in-plane resolution with large FOV of T1 to evaluate the entire pelvic lymph node basin should be done. Improper field acquisition can be overcome by synthetic MRI. This is a representative image of synthetic MRI from a 57-year-old male patient with rectal cancer. We can see here T2 image, T1 map, T2 map, and proton density map. So how it works? It doesn't just produce standard images, it generates maps of the T1 and T2 relaxation times and the proton density in single acquisition, shortening the scan time. So it offers quantitative values that reflect the tissue's intrinsic physical properties compared to the conventional MRI, again in short scan time. We can also have improper tissue weighting and the diffusion restaging artifact we talked about before. So they can be overcome by doing PET MRI hybrid, DKI, which is diffusion cortosis imaging, APT, amide proton transfer. What are all these? This is a PET MRI image, not a PET CT. So we have the high resolution of the MRI and the metabolic activity of the PET. We can see here, this is a patient who received chemoradiotherapy. There is poor response to the preoperative chemoradiotherapy. Still, there is metabolic activity in the rectum, so there is still tumor remnant post-chemoradiotherapy. Unlike this case, this is a good response to a preoperative chemotherapy. We also have the DKI, diffusion cortosis imaging. It's an advanced MR technique. Its parameters can act as non-invasive biomarkers for histopathological characterization. It provides more precise information than the conventional diffusion imaging. It evaluates the tumor aggressiveness, predict response to neoadjuvant therapy, and assess the tumor heterogeneity by giving parameters as shown here, reflecting the tissue complexity beyond the Gaussian model of the conventional diffusion. Think of it that the conventional diffusion imaging, it shows the water molecules movement in between the tissue, while here it shows inside the cell. And also we have the APT, amide proton transfer. It's a novel MR technique used for detecting and quantifying the endogenous cytoplasmic protein without using contrast. In other words, it's achieved by detecting the chemical exchange rate between the amide proton and the bulk water. So for example, if I have high cellular proliferation and high protein synthesis, so this is a malignant tumor rather than a benign one. And it also can show if this lesion is necrosis or a tumor. Necrosis post-therapy. Also, we have a limitation in identifying T1 or T2 stage of the tumor, whether it's invading the submucosa or invading also the muscularis propria, as MRI doesn't yet have the resolution capable of enabling differentiation between T1 and T2. So we can use the endoscopic ultrasound. Here we have, this is endoscopic ultrasound with the mini probe P letter showing a small tumor located within the mucosa and superficial submucosal layers with preservation of the outer layers of the rectal wall. So this is a T1 stage tumor. Also, we have difficulty in detecting EMVI, CRM, or MRF detection, or whether some lesions surrounding the rectal cancer represents lymph nodes or deposits. So here we can have the help of AI, artificial intelligence, and deep learning models. It's complicated. Their idea in a nutshell is think of it as teaching a computer to see and understand medical images just like a radiologist would. Deep learning models are like very smart pattern detectors. They look at thousands of rectal MRI scans and learn to spot features like tumor boundaries, lymph nodes, or signs of spread, just like a student learning from examples. So what can the model do? It can do tumor segmentation, outlining the tumor automatically, staging support, predicting the T stage or lymph node involvement, treatment response, assessing how well the tumor is responding to chemoradiotherapy, and surgical planning too, identifying the MRF involvement. So all these tools can speed up workflows, reduce human error, and ensure consistent high-quality interpretations. But these models, however, still need careful validation. They are not replacing radiologists. They are augmenting them, helping reduce fatigue and focus on more complex decision-making. Other emerging trends, we have substaging and more granular T3 classification, like not just T3 versus T4, but subdividing the T3 based on depth of invasion as that influences risk. We have improved restaging frameworks and protocol harmonization, and we have structured reporting and lexicons updating, like the Society of Anal Canal and Rectal Cancer has updated MRI staging templates and reporting lexicons and still refining definitions. And lastly, we have improved surveillance and follow-up protocols for early detection of regrowth or recurrence. Those are the references. Thank you.
Thank you so much. Any questions or comments? Thank you. So